Welcome Dr. Ayelet Spitzer. She is the interim director of the Valley Medical Palliative Care Program, and we welcome her and thank you for sharing with us today, Dr. Spitzer.
Sure. Thank you everybody for joining. Today we were gonna talk about the doctor-patient relationship and really share decision making. What does it mean? How do we do it? So we'll be able to, hopefully by the end of this talk, we'll have a better idea of what that means. I want to start with a story. The details may differ from your experience, but I think the underlying issues ring true to many of us. And this is a totally made up story. So if it sounds familiar to you, it's not you specifically. Mrs. T celebrated her 73rd birthday 2 months ago. She reached her 70s feeling well, and she'd been managing her diabetes, hyperlipidemia, and hypertension with only 3 medications. She was at a healthy weight and she was fairly active. She enjoyed walking her dog, and she walked 1 to 2 miles a few times a week with friends. After she turned 71, she noticed that she had pain in her knee and she wasn't able to walk as far. First, she tried over-the-counter pain medications, and after a few months, she noticed that those weren't working as well. After an exam, her primary care doctor ordered x-rays and recommended steroid injections. The steroid injections initially felt like a miracle cure, but then 3 months later, the pain returned. After 2 more steroid injections, her doctor recommended stronger pain relievers. Mrs. T was uncomfortable using those medications because she heard a lot about the risk of addiction when people took them. So Mrs. T was referred to an orthopedic surgeon. Here you are looking at images of arthritis. You can see when they say bone on bone, this is what they're talking about, that the bone here is basically on the other bone, and that's what causes the pain. After a few months, Mrs. T finally had an appointment with the orthopedic surgeon. The surgeon was well known in her city and had a reputation for a new surgical approach. He reviewed her history, examined her, recommended a knee replacement, and explained that knee replacements have a 90% success rate. Sounds great. She was scheduled for the next month. Surgery seemed to go well, and Mrs. T was able to go home quickly. She worked with physical therapy 3 times a week, but after a few months, she still had significant pain and she wasn't able to enjoy her daily walks. Her surgeon explained that it's possible, and up to 20% of patients who have knee replacement surgery still experience pain. She was frustrated. She went home and she started researching other options online. She found some things that she had not heard about before, and she wished she had heard about them before her surgery. She met with another doctor and asked about PRP, or platelet-rich plasma, and hyaluronic acid injections. She learned from the doctor that these modalities are not shown to have significant success and that there are some risks associated with them. But she was able to have a conversation with her doctor, and the doctor understood that she understood the risks and the benefits, and the risks were relatively low. She wanted to give herself the best chance possible to getting back to walking. She decided to try the PRP injections. After these injections were done, she did not notice significant improvement and continued physical therapy, eventually getting back to her walks, but taking them a little bit slower. When a friend asked her for a recommendation to help with her knee pain, Mrs. T recommended the second doctor. So like I said, I think that story really does ring true to a lot of us, where you go to the doctor, you get information, sometimes you're told information, and you don't always get the full picture, and then you look back and you wonder what happened. So what happened here? Neither procedure worked as she would have hoped, so why the recommendation for the second doctor? It sounds like to me, and I'm sure to many of you, that her experience guided with her doctor, each doctor guided her to this recommendation. With the first doctor, she initially felt well, but she felt dismissed on follow-up. And she felt that the doctor didn't really explore all options with her and didn't explain that continued pain was actually a common problem. The second doctor listened to her goals, explained her options, as well as the risks and the benefits. He allowed her to ask questions and ultimately to make a decision based on her own values. So what is shared decision-making? Shared decision-making is also called informed decision-making or patient-centered decision-making. It's a process by which both the patient and the physician or the provider share information with each other and participate in the discussion making process in the discussions and agree on a course of action based on those discussions. And this relates to all aspects of medicine. It prioritizes patient autonomy. It doesn't prioritize blind patient autonomy, though. It prioritizes patient autonomy with the guidance from the medical team, as well as other important influences in a patient's life. It doesn't mean that a patient makes every decision without help. It's more like the patient is the captain of the ship and gets input from all, the whole staff, all the crewmen, and then makes a decision based on that information. Why is this so important? From a doctor's point of view, shared decision-making can result in improved adherence to a treatment plan and at times improved health. From a patient's point of view, it can help make a patient feel empowered in their own health. It helps them to feel valued in their relationship with their physician. And this is what we often see a breakdown in medical care. We see breakdown in the model of shared decision-making that Mrs. T felt that her only option was what her first doctor recommended. He didn't fully explore other options. He felt that the evidence for their success was low, so it wasn't worth discussing. Ultimately, she was unhappy with the results, not necessarily because of the outcome, but because she didn't participate in decisions about her own health. With shared decision-making, ultimately, we see an improved doctor-patient relationship that looks more like a partnership and a relationship that, rather than a relationship that mirrors paternalism that used to be so common in medicine. I do want to talk about this paternalism. Historically, medicine has been paternalistic, meaning the doctor listens to you, makes a diagnosis, decides what's best for you, and then does it. And this theory, this theory was introduced in the 19th century, and it was the model for a very long time. It was based on the beliefs that a patient can't possibly have all the information that the doctor would have, and therefore was unable to make the right decision. So when we have a new medical condition and the doctor listens to you, makes a diagnosis, tells you what the treatment is going to be, doesn't listen to you, and then has results, you're left with unhappy people. What it really should look like, what this decision-making process should look like, is more of a patient-centered approach. The patient's in the middle, and the patient hears input from their doctor, input from their family, input from their faith, their culture, their friends, whatever things are important, whoever is important to them. And with that information, the patient then makes the decision for which treatment is the best for them. We like to say the right treatment at the right time and in the right place. And we know that that is different for everybody. Just because there is a path that works for most people, it doesn't make it the right path for everybody. So how do we do this? From the healthcare provider's point of view, their role is to describe the medical condition. Ideally, this is done in a way that the patient understands, layman's terms, not using medical jargon. I often hear doctors speak to patients using technical language to explain their symptoms. They're using English words, but it sounds like a totally different language. And this is true for people of all educational backgrounds, and even doctors who aren't in your field. When you talk to them in the technical language of your field, they might not understand you. So I think this happens because doctors spend a lot of time talking to each other, and sometimes we forget how we're supposed to speak to our patients. So it is very important to be able to speak in a language that your patients will understand, checking to make sure that they actually understand. It's also important for the doctors to actively listen when they're taking history. Studies show that physicians will listen to their patients for whopping 11 seconds before they interrupt. Other studies are a little more generous. They listen to patients. Those studies say that doctors listen for 12 seconds, but it's really not enough time to understand your patient. What's driving it? If it doesn't help you get a good picture, why do we do it? Sometimes there's pressure to see as many patients as you can in one day. Sometimes, and I'm sure all of you have experienced this, your doctor is busy typing while they're listening to you. Other times they heard some key words and a diagnosis clicks and they feel that they don't have to listen anymore. Doctors are often excellent diagnosticians. They understand a diagnosis and how to treat it, but that's not enough in caring for your patient as a whole. It's important to give your patient your full attention to understand what they are saying and how and what they might not be saying, reading between the lines almost, and then clarifying when you're not sure exactly what they mean. Active listening can also encourage improved patient participation. It gives your physician a good idea of what's important to you and to your family. You ask questions. That is something that's important to you. Some doctors try to do this with scribes. I don't know if you've ever seen a scribe sitting in the office taking notes, but it allows the doctor to give their full attention to the patient. And there are newer technologies that use AI to serve as a scribe, and the software will learn from the doctor over time. So the doctor can really talk to the patient rather than sit there typing. I have not personally used the AI technologies, and I understand that you might be very skeptical of them. I can tell you that from other doctors who have used it, they were all initially skeptical and they feel that it is game changing. So hopefully we'll have better technology in the next few years. There's also been a growth in something called direct primary care. It's also known as concierge medicine. And this allows the doctor to set the terms of their own visit rather than having the visit be dictated by requirements of an insurance company or a large health system. And it often results in improved collaboration between the doctor and the patient. So that's nice, but you didn't come to this talk for me to tell you what your doctor should be doing. So how do we learn how to be our own best advocates? So hopefully over the next few minutes, we'll learn a little bit more about ourselves and how we can communicate that information to our doctors. Before you even go to the doctor, or really before you have a serious medical condition, even now, you should consider your own values. What's important to you? What if you were no longer able to have it? Would it significantly reduce your quality of life? Quality of life is a term that's difficult to define, but it is different for each of us. And it talks about what you value in your life. So if it's family, is it being able to function independently? Is it being able to golf? These are all things that I've heard from patients of mine. Understanding these details about yourself and what influences these decisions is important because it can help guide you when presented with treatment options. If being independent is most important to you, and a certain treatment might leave you debilitated, requiring assistance to dress or bathe, you might consider that when speaking to your doctor about a proposed treatment. We also know that our family, our culture, our faith, our lived experiences, all of these influence our decisions. The medical information is helpful, but it's really these sources of influence that help us to make our final decision. Once you do that, it's important for you to talk to your loved ones. We often assume that our loved ones know what we want, and we don't take the time to discuss it until it's too late. I think, and it's, I think this is just very uncomfortable for people. We're wired not to think about the end of our lives, and nobody wants to have this conversation with a loved one. I think either on the giving or the receiving end. I'll even tell you I do this every day for work, but when it comes to talking to my own parents, it's a hard conversation to have. And they don't have to happen all at one time. It is important, though, that you are able to help your family understand your preferences. I wanted to bring up some resources here. These are a few different websites. Maybe Sue, if you could email out the websites at the end when they get the survey.
Sure.
Okay, so there's the Conversation Project. each of these websites have a slightly different style. So the Conversation Project, it's an initiative from the Institute for Healthcare Improvement, and they found that 92% of Americans want to discuss their end of life preferences, but only 32% have actually had a conversation. And they have several guides ranging from What Matters to Me, which is a workbook, or How to Be a Healthcare Proxy. Death Over Dinner is a little bit more provocative, but the idea behind this organization is that discussing these issues, end of life issues, is a gift that you can give your family. And it acknowledges that it is hard, but if we bring it to a normal part of our lives, it helps you to maintain control over the process and you take the burden of decision making off your loved ones. There's another organization that people may have heard of called Five Wishes. This organization focuses more explicitly on end of life issues, and it might not be the right place for everyone to start, but it can be very helpful. Okay. You may have noticed that I didn't talk about advanced directives and living wills. Those are different terms for the same thing. An advanced directive, it's a document through which you designate a healthcare proxy and you state your wishes for end of life care. They're often, but not necessarily, put together by a lawyer. And nothing against lawyers. My husband's a lawyer. And they're kept in your lawyer's office or your safety deposit box, sometimes never again to see the light of day. When these are done correctly, they're invaluable. But the text is often boilerplate without specific wishes. And more often than not, the designated healthcare proxy is unaware of the document or its contents. I wanted to highlight this term. This, if I should suffer a severe and incurable injury, disease, or illness certified by at least 2 physicians, one of whom may be my attending physician, to be such that the application of life-sustaining procedures would only serve to postpone my death, and where my attending physician determines that my death is fairly predictable within what he or she considers to be a relatively short period of time as a consequence of the condition or related complications, whether or not life-sustaining procedures are utilized, I direct that such procedures be withheld or withdrawn and that I be permitted to die naturally. That sounds very complicated. Basically, what it means, ultimately, at least my understanding of it, is that if you have a terminal condition, you don't want life-sustaining measures. Now, that's how I interpret it. I will tell you that I did have a family member of a patient prepare an advance directive for the family member. And when I asked him what it said, he said, oh, these documents aren't like all legal documents. They're meant to be interpreted in several different ways. That's not how you want your advance directive to be worded. You want it to be specific to you. Yes, it's true, you will not be able to think of every possible outcome. It does help, though, that if you understand your values and you come up with a philosophy of care almost, or how you'd like to live your life, you can apply that information to the decisions that you're being asked to make. Will this procedure help me get to my goal, or will it make it harder for me to get there? And that helps your family members understand also in case they're asked to make those decisions. So now that you've considered your wishes and communicated with your loved ones, you need to relay this to your medical team, particularly your primary care doctor, who will often serve as a point person for your medical care. Before you do this, I do want to clarify that Medicare, and therefore many other insurance companies, they actually reimburse your doctor for having these conversations. You may want to clarify when you make your appointment that this is what you want to talk to your doctor about, so you can be sure that they'll have the time to sit with you and really explore your wishes. Understanding your values is only part of this discussion, but it helps to ask, part of the discussion will also be asking your doctor, what can I expect from this medical condition, or what are the most common side effects from a treatment? It also helps if you're able to explain how you like to receive information. Do you want to know everything? Do you want to know only the necessary parts? Do you want to know what your life expectancy is, or would that make you more anxious? Are you the type of person who likes to do research on your own? I do want to offer a word of caution about receiving information on patient portals. Patient portals are wonderful tools and help you to communicate with your medical team in non-emergent situations. However, in 2016, the Cures Act passed, and this requires that information be uploaded to the patient portal often instantaneously. That means you might get a notification that your results are ready before your doctor has had a chance to review them. Or it might mean that your information is posted on the weekend and your doctor's not in the office. It makes sense to wait until you're able to talk to your doctor about the information that you're going to see so you don't have to interpret your own radiology studies, or you don't have to understand what your labs mean. It's not that your doctor is trying to make you more anxious by not telling you when the results come in. We want to make sure that you get the information in an appropriate way so that you are able to understand it in the context of your disease. It's also helpful when you are receiving this information to have a family member or a trusted friend at the appointment with you. Most of us forget something like 70% of what the doctor says in a regular visit, so you can understand how you forget even more when you're hearing something difficult. A family member there can take notes, they can ask questions, and they can help you to retain more of that information. Once you receive a diagnosis, it helps to become informed about it. You should feel comfortable asking questions about a recommended treatment or procedure. Did you hear about certain side effects? What are the chances of having those side effects? What are the other side effects to expect? What's the likelihood that a medication or procedure will be successful? Being prepared with questions is always appreciated, and you can also ask your doctor for trusted sources of information to learn about your condition. Because when you go home and Google, and we all do, you want to make sure you have access to accurate information. I want to clarify here to remember what I said at the beginning, that you and your doctor may technically be speaking the same language, but the terms might need clarification. It is okay to ask questions. It's okay to write things down. It's okay to have someone else ask questions on your behalf. Even it's always going to be helpful for you and for your doctor to have that there. Then there's understanding commonly used words. Hyper and hypo, to me, I understand what that means, but maybe you don't. Any acronym, ask what it stands for. What does it mean? It'll help give you clarification on a procedure or a condition. Success is a big one. Success to you might mean that you're able to get back to the life you enjoyed prior to the intervention. To your medical team, it might be that you tolerated the procedure well, you were able to get home within a few days. That can help explain the difference between the 90% success rate that Mrs. T's first orthopedist touted and the 20% of patients who still have pain after surgery, way back in the beginning of this presentation. Something else to understand and to ask about are the risks and benefits of a procedure, of any medication, but also to look at it the other way and to understand the risks and benefits of not doing a procedure or medication. For example, dialysis is frequently offered to patients with deteriorating renal function. It represents a huge lifestyle change. For some, knowing that they'll have life extension because of dialysis makes it worth it. But not everyone is a great candidate. Recent studies show that for some populations, starting dialysis extends life for maybe 80 days over 3 years, and more of that time is spent in the hospital. So there is a benefit to not doing dialysis for some people. Maybe they get to spend more time with their family out of the hospital and feeling well. Your doctor might assume that you want to be offered all life-sustaining measures, and they may not fully explore your wishes. So please ask the questions. Why yes and why no? Another invaluable aid is other patients who have gone through something similar. Support groups are great resources, and people who participate in these groups can help you understand the lived condition in a different way than your doctor can. If you can't find a support group or you're not ready to sit in a big group, it's okay to ask your doctor if they have any patients who might be willing to speak to their experience. So going back to our original story, you can see how Mrs. T was able to partner with her second doctor. She understood the options that were available, what was expected as a result of the treatments, and she was able to maintain control over her own health. She was allowed to ask if she did not understand something or if she heard something different than what her physician said. Even though she didn't have the outcome she hoped for, she felt that she mattered in the discussions of her own health. And I hope after this talk, you do feel empowered to participate more fully in your healthcare decisions, that you know what questions to ask and how to get the information that you need, and also how to give over the information that you need to give your doctors. And for anyone else who wants to read a little bit more about this, um, I highly recommend the book The Art of Dying Well by Katie Butler. I actually recently read this book and I felt that it was very clear, it was very helpful, and it was also very hopeful. So it does give you a really good idea of what you should, how to understand things about yourself and how to communicate that with your doctor. Um, that's everything I have for now. Does anyone have any questions?
Thank you so much. That was so interesting, comprehensive. I think so many people talk about just not even knowing what to ask sometimes, and it really has changed so much in terms of people being an active participant in their care compared to years ago. We all just kind of listen. So thank you. I don't have too many questions. I think one of the things that I've been asked as a social worker and someone who refers to hospice and palliative care, and when do you think you should like maybe start to think about like as you get older, advanced directives, having some information written down regarding your healthcare interests? What would you
That's
say?
such a that's such a good question, and I actually did not put that slide in, but um, you can start now, really, before you have any medical conditions. If you think about what's important to you, there won't be pressure on you if something were to happen. Designating a healthcare proxy, someone who you trust to
Mm,
honor your wishes, you can start that now. If you're diagnosed with a serious medical issue, you can start an advance directive based on the information that your doctor is giving you about your condition. I expect that in the next 5 years, you will become weaker. You might not be able to walk as well. Whatever the doctor is telling you, try to fit that into your values and come up with a good plan. Over time, we recommend a post form, which is a medical order that is supposed to mirror the advanced directive. I do want to say advanced directives are nice, they're very helpful, but they're really just instructions. So as long as you are designating a healthcare proxy and having a conversation with them about what's important to you, what you value, they'll be able to honor you in the best way that they can.
it's really helpful. Thank you. Somebody was just saying thank you. This has been extremely helpful. It really has.